Good morning, everyone. I think the take-home message is here is that think about our lung cancer population, fit and unfit. And all the first-line pivotal trials for immunotherapy has transformed the treatment of lung cancer, but they're mainly restricted for people with good performance status that are fit patients. And important to remember, the real world, we have this big population of lung cancer population who are unfit for our standard doublet chemotherapy. And that's an important message to take home. This is the population we are focusing, and we think there are at least 40% and of these elderly patients who got multiple comorbidities who we just cannot treat with our standard chemotherapy or even immunotherapy cocktail. And we treat them with less effective single-agent chemotherapy or send them for best supportive care. So I'm going to share with you the first time we ever conduct a study on this unfit lung cancer population. So first slide, please. Oh, sorry. So nothing to declare. So I just mentioned the pivotal first-line trials changed treatment practice, but they are mainly confined to good performance status fit patients. And we are focusing on this big population of unfit elderly patients, comorbidities, multiple drug medication, and we are examining the role of first-line immunotherapy treatment with atezolizumab. So straightforward design, first-line treatment, unfit patient, EGFR negative, you can see on the slide, simple randomization, standard immunotherapy, atezolizumab, or they get single-agent vinorabine or gemcitabine until disease progression. And this is the results you all are waiting for. So we met the primary endpoint, OS hazard ratio 0.78, 22% reduction. And not only that, you look at the one-year survivor, pretty impressive, 43% or 44%, way better than we saw with our historical data using doublet chemotherapy for good performance status. And more importantly, at the 2 years time point, we see a doubling, 24%. One in four patients of these poor elderly patients with a lot of comorbid problems still alive at 2 years. And our response rate, you can see, as standard for our single-agent chemotherapy, 7.8%, but you see a doubling of response rate with just single-agent atezolizumab. And one of my patients still alive 4.5 years in CR. And you can see the median duration of response is also double. So pretty impressive with just immunotherapy alone for this frail elderly patient, median age 75 years old. And not with all the pivotal study where the median age is less than 65 years old, ranging from 61 to 64, who are fit for standard doublet chemotherapy, platinum doublet chemotherapy. So, and not only that, you look at the quality of life, and where the scale above the x-axis is improvement and below is deterioration. So you can see this atezolizumab not only helps with their quality of life, there is stabilization of this poor patient, role function, cognitive function, social function, and also time to deterioration of chest pain, you can see on the right. And there were other symptoms that we saw, appetite loss, cough, we saw with atezo arm, whereas it's deterioration with appetite loss, neuropathy, and alopecia with the chemo patient. So toxicity, okay. You get more treatment duration with atezo. You can see the treatment cycle there. They get about double the duration of treatment. And they also get about double the number of treatment cycle. But despite this longer duration of treatment with atezolizumab, you can see the toxic side effect is not too bad. So treatment-related grade 3/4 AE was only 16.3% for atezo patient compared to 33.3% for the chemotherapy patient. So this is a take-home message. First-line immunotherapy with atezolizumab significantly improved survival. It met its primary endpoint, hazard ratio 0.78. For the first time, an elderly population of 75 years old compared to all the pivotal trials which were less than 65 years old. So hazard ratio 0.78, double the number of patients, impressive one-year survivor, 1 in 4 patients still alive at 2 years. And quality of life, as you've seen, stabilization, some improvement, and we did not see any safety concerns in this poor population. Just remember, poor, elderly, with a lot of comorbid problems. Thank you very much for your attention.